Welcome, everyone. This is Shabir Musa. I'm the family physician in Johannesburg, the president of Wonka Africa. Thank you all for being here, and I'll just give it about 2-3 minutes to see who else is able to join us. And just prepare a quick something for us to start with. So we have together with us Joy Mugambi, who's a family physician from Kenya, and I'm sure Joy will give us a little bit more of an introduction. We also have on the call via WhatsApp call, so apologies for the quality of call, but David Lusale from Zambia. David, welcome.
Thank you.
Good. And so hopefully, Joy, you can just tell me if the quality is a problem, but the objective in us meeting is basically to look at what AfroPHC is all about and what the key stakeholders in AfroPHC, who they are, who the people are, and what their thoughts are about AfroPHC. So I'm going to start, perhaps I can start with David from the, David, do you mind introducing yourself in the organization, talk a little bit about that, and then we'll then go to Joy to talk about Wonka. David.
Thank you. Good evening. Right, David Lusale. At the moment, I'm the trustee for the Africa Network for Clinical Practitioners, and I'm the immediate past president. So this brings together the clinic officers, the assistant medical officers, the medical licentiates, the associate clinicians in.
Go ahead, David.
Africa.
Go ahead, David. You would David's.
Practitioners could have a community. Hi.
Yeah, I think we're missing you a little bit. If you don't mind repeating the last 2 sentences.
Yes. The main objectives, among others, was to bring these clinicians together so that they could have a platform to interact, but as well as network with other stakeholders within the healthcare industry. But besides that, they were interested to advance their researches about their profession, as well as advocate for good training and also good evidence-based practices as they save their community.
Right.
Communities with the best kind of care. It's an organization.
Sorry, David. Have we cut you off there? All right, David, perhaps we can just pause there.
Yes.
Sorry, we can pause there a moment and ask, maybe I'll come back to you to ask a bit more questions about how clinical associate clinicians function, in which countries they are, and a little bit more detail. Perhaps we can get Joy to just briefly talk, and then I'll come back to you to get a bit more detail. Joy, do you want to share as yourself as a secretary of Wonka Africa a little bit more about yourself, the organization, and briefly the objectives, much like David has just done?
Thank you. My name is Dr. Joy Mugambi. I am a family physician in Baringo, Kenya. And at the same time, I'm the Secretary General of Wonka Africa. Wonka is the World Organization of Family Doctors. It's divided in 7 regions based on the continents. And we, as Sub-Sahara Africa, are the ones that run Wonka Africa. Wonka Africa aims to advocate for equity in Africa, develop quality primary health care services and strengthen clinical teams with family doctors leading the teams. And we encompass also our associates who are also the clinical officers, the nurses, community health workers. And our aim is also to strengthen the training of clinical teams, undertake research for Africa evidence, and advocate for policy to support this. So that's basically what we aim at as WONCA Africa. And also within WONCA Africa, we've got our executive leadership. Professor Shabir, who's the moderator of this session, is our president. We've got our treasurer, who's Reggie, and she's back in South Africa. And we have our president-elect, who's Dr. Dan Abubakar from Nigeria. We've got the team of 2 members at large. That is Jane Namatovu from Uganda, and we have Temitope from Nigeria. Within WONCA Africa, we have a young doctors movement. This aims to bring the doctors who are in family medicine residency, the young medical doctors who are also in training, and also those who have just qualified 5 years into practice. The aim of having a young doctors movement was to mentor the young doctors into leadership and to grow into WONCA Africa as they move on in their career. Within WONCA, we also have the WONCA Working Party on Women and Family Medicine. The WONCA Working Party on Women and Family Medicine has a chapter in Africa, and each country at least has a representative. They do represent the activities of WONCA Women, which aims at advocating for women's rights, ensuring that sexual and reproductive health rights are advocated for. And amongst the young doctors who are in training, the female issues are also sorted out within that working party. We have other working parties that are active within Africa. That's the WONCA Rural, that aims to enhance the practice of the family physicians who are in rural areas. We also have research, mental health, environmental health, and quite a number of other working parties that we are working towards engaging our members in. So in brief, that's WONCA Africa, and we continue engaging. Thank you, Professor Shabir.
David, do you want to add a little bit more details about the network of associate clinicians? So David's challenge.
Tahiti is here.
Is Tahiti there on the panel? Ah, there you are.
Yes.
Welcome, Albert. Albert Tahiti is the current president of the network. Perhaps, Albert, considering David's having challenges with the connection, welcome, and you're free to put on your video so that people can see you, enjoy as well. I think people would not want to look at just me alone, so please put on your video. So, Albert, can you hear me? Albert? I think maybe he's challenged slightly, but maybe Joy, if you could just try and reach out to him. So David, maybe as we wait for Albert to come along, would you like to just share a little bit more about where clinical offices are across Africa, and how does it, how does the organization function? Do you want to share a little bit more about the association?
Yes. So the Africa Network, currently at the moment we are in West Africa and also Central and South Africa.
Okay.
Up in West Africa, we have our members known by different nomenclatures, but their job function is more or less similar. So we have the assistant physicians in Liberia. They are part of this membership.
Good.
We have Ghana. They also have the physician assistants programs that they started in the last decade. They are part of our members. Then we have Ethiopia with emergency surgical officers and the house officers. They subscribe to these organizations. Then in Rwanda, they also have the clinic officers. Tanzania.
Are they all termed
Malawi,
clinical officers in that region?
Zambia itself.
David, are they all termed?
In the East Central, in East Africa, almost all of them are clinical officers, except for Tanzania has two groups. The higher level, they are assistant medical officers. Then Malawi, they train the clinic officers. Zambia, they do train the clinic officers. Then those higher taking up also some surgical roles are known as the medical licentiates. Then we have Mozambique. They have surgical dysarthria or surgical technicians. And eventually, I think thinking of giving them a title, the clinic officer in the long run. Then South Africa itself, they are part of our members, and there you have the associate, the clinical associates. So these are the members. Now, in terms of some of the roles that we've been there, of course, it has been to advocate for more recognition. Some of our members in their countries. So like because that is some of the programs started as much as far back in the 1920s. Fight visibility because in most forums, medical symposiums, it be international conferences, they seemed not to like the platform instead to have a platform of representation through the organization. And so far they've been able to mobilize themselves and they've been able to hold regional conferences, at the same time participating in international conferences. And most recently in Mombasa in 2019, it was a very successful meeting that we had. In terms of the executive, of course, it draws members from the associations of each country. So those who are presidents, they form this college of representatives who meet or discuss through WhatsApp or other platforms, electronic platforms, to plan and they also implement some of the activities that they think members should implement. On advocacy, of course, so far we have seen on the side of education and training, some countries create the career paths for them. So some have now begun to think about developing programs at the master's level rather than the undergraduate level. So that is very good for us. And in terms of networking, we have also joined hands and networked quite well with some international, like the International Academy for Physician Associates. These are basically, they are educators who are this global organization. And that has been very, very helpful to learn and borrow activities like research. So in terms of research, though it has been much more about what there has been in their various countries, we see now also concentrating to contribute on research on what we think are best practice interventions to improve the healthy and welfare of our peoples.
Yeah. Well, thank you, David. I think that's really useful. Perhaps, Albert, I know there's some questions. Please post your questions on the group, and I'll try to manage that we ask it. I think there's one already. Albert, do you mind sharing your thoughts a little bit, or if you feel anything that you'd like to add if you just tilt your screen slightly forward, and then we can see you nicely, Albert.
Hello?
Hello, Albert. Yep, just pull your screen slightly forward so that we can see your face better. And
yeah, you hear me?
Yes, we can hear you very well. Good, Albert. Do you want to share a little bit about the organization?
Oh, thank you so much. As you have mentioned my name is Albert Taiti. I'm the national chairman of the Kenya Clinical Officers Association, and also the current president of the African Network of Clinical Practitioners, having inherited the position from Dr. David Lusare from Zambia, who has just been speaking. I'm quite glad to join you this evening, and I'm quite happy because this is a platform that will be able to make us come together as Africa, because it is a tall order and a challenge to bring Africa together.
Very much.
So maybe just to basically give you the preliminaries and how we are structured in Kenya, and we have the clinical officers basically in two categories. The diploma clinical officers, who are normally trained for 3 years, and they go for 1 year internship after qualifying from the colleges. We also have the second category, which started sometime in 2010, the Bachelors of Science in Clinical Medicine and Community Health, trained in more than 10 universities currently. For the diploma, we are training in more than 50 colleges, and the diploma, after they are through with their training and internship, they can as well be able to proceed, and they are normally given some credit transfer and waiver, where they take the program for 3 years to become BSc holders, but they still have to do another 1 year internship. For the bachelors, we have two categories: the upgrading, those who are coming from diploma, and also those who are direct entry from secondary school. The direct entry go for 4 years and 1 internship. Currently, we have also we are working very hard, and we already have one of our universities offering master's programs for our clinical medicine, those who have already acquired their bachelor's degree. And we have masters in emergency, accident and emergency. We have a masters in family medicine. We also are having masters in forensic medicine. We are also working with another public university to come up with masters in child and adolescent health. Also masters in oncology and palliative care, and masters in maternal and reproductive health. basically those are the ones we are really working on. We are doing a lot of advocacy. There is some, of course, some little bit of resistance here and there, but we believe this will come to pass, because even when we were starting the bachelor's of science in clinical medicine, there was also a similar resistance. We have done quite well in Kenya because with clinical medicine, it is quite well structured. The program is a training and practice is regulated by the Clinical Officers Council, which is a government regulatory body under our Kenya Laws Clinical Officers Act number 20 of 2017, which is a review of our earlier law, which was CAP 260, which somehow it helped us all right to practice, but it had quite a number of limitations. Right now, the current law allows us to practice as per our training. Then we have an association which started in 1962, and it was officially registered in 1981 under the office of our Attorney General, that is by the Registrar of Societies under Societies Act. This association, which is now the Kenya Clinical Officers Association, which I chair, is the one that was able to lobby for our law, which gave us our regulatory body. And just recently, when I took over as the chairman of the association, that is in 2016. By 2017, we were able to lobby again to have a trade union, that is the Kenya Union of Clinical Officers, so that we could be able to separate the roles of the council, which is a regulatory body, the roles of the association, which is purely professional development and professional welfare. And now we have the union, which is taking care of the labor and trade issues, so that we don't have a mixture of the three. But all these bodies are working together. In quarterly, we normally have a meeting for the union leadership, top leadership, the association top leadership, the council top leadership, and also the office of the director of clinical services, who is our head of department in our Ministry of Health headquarters. So basically, that is how we are working, and this unity of purpose has really helped us to achieve quite a number of things, because when we approach them from a common front, we are anybody would want to hear what we are talking about, and this is how we are trying to achieve some of these things, including now bargaining for our position as primary health care workers, because we normally say for the secondary care of the patients, we leave it to the medical officers, and we are saying, because we have different levels of service provision, from the lowest level, level 1, which is the community, level 2, which is the dispensary, level 3, the health centers, level 4, the sub-county hospitals, level 4, yes, the sub-county hospitals. We have the level 5, which are county hospitals, and then the level 6, which are national hospitals. And of course, we have the specialized hospitals, the hospitals that deal with specialized service. And we are saying from up to level 4, clinical officers can comfortably handle. And then we are saying we may not have much to do with the level 5, 6, and 7, although, again, because of our specialties, I forgot to mention that clinical officers, even after diploma, some of them normally go for post-basic diplomas, which are specialties. And these specialty clinical officers who are specialized are the ones who have been giving specialized services, and they play the role of consultants in most of these county and sub-county hospitals. And therefore, clinical officers are serving in all levels, up to even our national hospital, like Kenyatta National Hospital and Moi Teaching and Referral Hospital. Thank you.
Well, thank you. I think that's quite comprehensive. I think there's some questions. I'm going to just say thanks to Heather McGrath, who's a family nurse practitioner in Jamaica. She's on the team. She hopefully will not leave too quickly. But I just wonder about the question also coming from Steve Osome, who's talked about the question of how do family physicians, I think when he says family health clinicians, and Walker think about the placement of these cadres. And I think that also maybe from Kenya. I think that'd be an interesting question. How do you as clinical officers, and maybe Dr. Mugambi can also talk about it as well, how do we see the team functioning, and what are the difficulties, if there are any, in teams between family doctors, clinical officers, or clinical associates, or and nurse practitioners? How do you think we will go working together going forward? Are there challenges and issues? Perhaps
I think
Joy, you could start, and then we can get between David and Albert to just respond.
Okay. Hi, Albert. Thank you very much for joining us. Albert is someone we've worked for so many years with. It's nice to inform you that I was a clinical officer before I went for my degree and did medicine and went into family medicine. So I've done the whole 360 of primary healthcare, and it's a privilege working with clinical officers wherever I am. And I'm glad to say I did work on development of the curriculum that we've been asked by Onsome how it will go about. We developed the clinical medicine higher national diploma in family medicine, along with a higher national diploma for the nurses and community health workers that draws them into the family medicine principles. Though being the first cohort that has just graduated, yes, there is challenges in terms of placement within their specific counties, mostly because we are not a very large cohort of family physicians in Kenya. That starts there. And also now there is not a very large cohort of the family medicine higher national diploma clinical officers and nurses. So building teams is still a challenge. But one more thing we did last year was develop the primary healthcare strategic framework, because this now guides the government in terms of where the family physician will be placed, where the higher national diploma family health clinician will be placed, and where the nurse will sit in when it comes to the structure of family of primary health care within the country. So the strategic framework was launched last year, and that strategic framework is yet to be adapted in various counties, but we do hope that that happens. In my facility in Baringo, Eldama Ravine, I encouraged one of my clinical officers, and she did take the higher national diploma in family medicine. And we are now running a family medicine clinic, which we link up with the community. These past 2 weeks with the COVID scare, it's been hectic for both of us because our work has been mapping the communities, trying to identify who traveled in. But it's been so much fun because this has really brought us together and showed what really family medicine is all about, and working as teams along with the public health department, community health workers, the community itself, religious leaders. And we hope with what we are doing as a team, we'll be able to put down something even on paper and demonstrate what really a whole primary healthcare team can do in a rural setup. So I hope that answers you a bit. It's part of the teamwork that you will engage with your family health practitioner, the family physician in your county, that will make a big difference. So on some, reach out to a family physician next to you and see what you can do as a team, and demonstrate to the government that, yes, truly primary health care in teams works in the best way.
Thank you, Joy. Thanks. I'm just wondering, perhaps between David and Albert, you can respond. I think we're trying to see, you know, in a way, the clinical officer, primary care nurse, and family physician are emerging in a bit chaotic space in Africa, where people jump to different things, and we ultimately have a shortage, and we need everyone. So, but how is it emerging? Are we finding ourselves tripping over, or are people slipping into good teamwork, and maybe just the nurse clinical officer dynamic? Do you would like to share something? Maybe David, you can speak a little bit, and then Albert can continue.
Yes, thank you, Wonka. I follow Joy.
Good.
I would like to say, of course, about the opportunity to visit some of the African countries, specifically with the objective of seeing how the clinical officers or clinical associates alike are working, and also how they relate with the other professionals. What I find is that relatively the younger the profession or the younger the program started, because of their visibility, they are not yet well known. Of course, teething issues do exist. Either the nurses don't understand them very well, but eventually where they begin to know what their job is like, and that they are not there to take anybody's job, which usually is the misconception, then things tend to work well as teams.
Yeah.
But the other side of it, when it comes to the family physicians or the physicians, tend to work very well with this kind of heart rates. And you'll find that the synergy, even in primary healthcare, tends to work very well because they are able to delegate, and the subordinates also are able to pick up those delegated duties or assignments fairly well and with motivation. And to go higher if one takes some studies.
All right. No, thank you, David. Let me ask Albert to continue.
However, for the youngsters,
okay, sorry.
most of the time I find that because of this misconception.
Yeah, David, carry on. Sorry, we're missing you. It's disconnecting slightly, but carry on.
Yes, Albert, also clear.
So do you mind just saying this quickly again, the last 2-3 sentences? All right, let me ask you to continue. I'll just, sorry, David, if you could just wait because of the difficulty, let me ask you to just wait a bit. Perhaps, Albert, you can respond. How do you feel about teamwork and the different cadres emerging in Africa? How are things going generally with the relationships between nurses, clinical officers, and family physicians on the ground, or doctors?
Okay, thank you so much. I think I want to appreciate Joy, who was one of us, or who has been one of us. No, she's still one of us because she really loves the profession. And we always say, once a clinical officer, always a clinical officer. In fact, she's one of my senior clinical officers. I also want to appreciate David, because of the good work they are doing in Zambia. And I want to state clearly, and maybe just to put more emphasis on what David has said, that clinical officers, everybody appreciates the work the clinical officers do down there. But again, because all of us would want to fight for our space. When clinical officers are coming in, some people fear that they are coming to provide some competition of some kind, or they are coming to take up their work. But after they have understood them, like for us in Kenya, in the last about 3 or so years, we've been fighting very hard to ensure that people know whom we are. Because most of the work that clinical officers have done for many years, it has been construed that it is the doctor who does it. The public did not know the difference. As long as you are in white coat and a stethoscope, people thought that all of us are medical officers. And in the real sense, more than 80% of those people who are working for the people from at all levels of service provision were clinical officers. And therefore, we just decided, as from around end of 2016, that we shall no longer, even if the community call us doctors, we shall always make sure that we inform them and we let them know that we are clinical officers. So that at least when clinical officers do the work, everybody will know that it's the clinical officer doing the work. And also with the time, we have also been appreciated by even the medical officers. We have been appreciated by the nurses, and we have made them know that we are not coming to take any of their duties, and we are ready to work with them. And as per now, there is very good teamwork. Because when it comes to theater, we have clinical officers up to almost 95% of anesthesia services, or the anesthesia given by clinical officers. If you look at the TB services, TB, that is tuberculosis, treatment of patients with tuberculosis, and chest medicine, is also done by clinical officers, and with the support, of course, by nurses and some medical officers, maybe being the head of the programs and all that. So basically, gradually that teamwork is being embraced, and the conflicts or the disputes which could have been seen to be there, somehow they are fading away. So I can say, especially when we have the rights of Joy Mugambi, if we have 5 of them, I know we shall be able to have very good teamwork and with very good team leaders. Thank you.
Thank you. I think that's good. Joy, maybe you want to respond about how things work together, Joy? The sort of teamwork issues you've mentioned a little bit.
Yes, I would say in every country, in every country in Africa, if we do work as a team, will really make a big difference in the primary healthcare platform. We all need each other, and the space has plenty for us to offer. If we do come together and work as a team, will really make a very big difference. I see a comment from Dr. Mzungu.
You can respond to that, please.
Yes, great input, my Dr. Joy Mugambi live. The passion for family health, however much negative perceptions from other specialties, that family medicine is not a specialization. These few people joining need to be addressed with lessons learned from Cuba. Thank you very much, Mzungu. Mzungu is a colleague of ours who's in Nakuru.
Yeah. So what do you think? How do we attract more doctors into family medicine?
I think it starts with advocacy and ensuring we get out more information out there of what family medicine is, we need more research in primary health care. And I think the only way we can get that research out is working with the clinical officers. Last year, when the clinical officers had the twin conference that was in Mombasa, the one that David mentioned earlier, I was part of the scientific committee, and I can tell you the papers presented by the clinical medicine team were extraordinary. And if we came together and did more in terms of what is available in the primary healthcare space, what are we doing in the primary healthcare space, we really would make a big difference as a team rather than working in silos out there.
Absolutely. So I think that one of the things that I'd like to just shift the conversation to is, how do you feel about the AfroPHC, this attempt at trying to bring us together? Albert, perhaps you can just respond to that, and then Joy and then David. What are your thoughts about AfroPHC? We're almost close to the end of the hour, so we'll have to close on that. Albert, do you want to share your thoughts? If anybody has questions, please feel free to put them out. So David, if you are on the call, you're on them. But go ahead, Albert. Sorry. Go ahead.
Sorry, I didn't get your question.
What are your thoughts about AfroPHC, this effort to bring us all together?
Thank you. I think, if I may be very honest, at first I didn't know about it.
Yes.
I was told about it by Joy, my senior clinical officer, and I say this is a God-said opportunity for me, because being the president of the African Network of Clinical Practitioners, I honestly need platforms like this, because we need such platforms to be able to bring all these people together, people of like minds, and also bearing in mind that the African Network of Clinical Practitioners, the members or the people involved, it is a society with the membership by associations. And these associations are made up either of clinical officers or analogs of clinical officers. And right now, the struggle I have, and in fact, I'm planning to really work with David in a big way, because we need to get all these people together, all the way from North Africa, West Africa, to East Africa, down all the way down to South Africa. We need to identify all these analogs of clinical officers. We need to know their curriculum. We need to know how much they are trained, and we need to know how we shall be able to network together. This is one of the greatest opportunity we can have, and in fact, this is one of the things I would hate to miss, and I will try as much as possible to make use of it, because it brings the whole of Africa together. This is a God-said opportunity. Thank you.
Thank you. And I think we want to be able to help you as much as possible. So I really hope that you can reach out, even after this conversation, and we get a way to understand what you're doing, how we can be of assistance. So please, we're all part of one team. So I hope you'd come out and ask us. And I think we want to support you. David, perhaps you can do it, and then Joy can sort of close it up. David, would you like to comment? What are your thoughts about AfroPHC? Hello, David. Not sure, maybe he's...
His mic.
Yeah, let's just see. David, are you able?
Hello?
Yes, David, can you speak? Go ahead. David? Yeah. Yeah. You can speak?
Yes.
What are your thoughts on AfroPHC?
Yes, what I wanted to say, the AfroPHC. There is that echo.
Yes, I'm trying to.
Hello.
Yeah, I think.
AfroPHC is a platform where I see you bring multidisciplinary teams with you.
Yes. Go ahead. Don't worry about the mic on the.
Together, and
Yes.
that's one way of bridging those differences.
Yes.
So it's a very important platform.
Good. Good. And I think we need to, this is just the beginnings. I hope that we can continue
Therefore,
this.
I would encourage that the platform, with the strategy it has,
Carry on, David. Hello, David. Okay, perhaps Joy, I think we having battles with David's connection, but thank you, David. Yeah. David, sorry, the sound is becoming challenging. Perhaps, can you speak now and then we close it? All right, let's just give David a...
Yes.
Joy, would you like to close up on it? I think, unfortunately, David's challenged with the sound, I think. So let's just see how we can manage that. Go ahead. Joy, would you like to share what your thoughts are on AfroPHC and how we could take it forward?
Yes, I think there is also someone on the chat.
Yes, would like to speak. Yes, I see that now.
Yeah. Would you want to give him?
Yes, we can do that. Yeah. Perhaps you can just quickly say a few words and then we can allow the gentleman to talk. He's got 2 seconds.
For me, AfroPHC is a great platform. I look forward to a united front in primary healthcare where we are working as teams rather than silos and strengthen primary healthcare. Looking at case example currently with the COVID issue, everyone is working as an individual, each country, each county, each district. Only we had a united voice working in a structured manner would end up having to tackle the issues that we are facing in a much easier way, seamlessly.
Yeah. No, thank you for that. Doctor, I think, is it,
Francis?
I'm not sure the name? Francois. Francois, do you want to go ahead? Let me just allow you to speak. Go ahead, Francois. You want to say something? Francois? Sorry.
Francois, good evening.
Yes, yes. Go to speak, Francois. Sorry, you're able to speak now. Go ahead.
Yeah, thank you very much. It's a wonderful opportunity to join you in this forum and know what is happening all over Africa concerning primary health care. From Cameroon, I want to share a little bit of what we are doing in Family Health and Development Foundation.
Go ahead. Yep, go ahead.
Yeah. It's a young association that has a passion for primary healthcare delivery. We work in the communities, delivering healthcare to the last people in the community, the most vulnerable, and we give healthcare in terms of community health and maternal and child health, and that's most of the areas where we render services. And we had to send one of us to be trained in India on community-driven development. And so with our weak health system, we believe that those in the community really needs us. And so that is where we give much of the assistance. And so one of our objectives is partnering with other organizations, and being here today, hearing what others are doing is quite impressive. We'll be grateful if a hand of will be stretched out to us to assist us to continue working together as a team in Africa. Well, I don't know what time I had. I hope I will have another opportunity to share detailing some of the work we are doing and some of the challenges we have on the field. But we have a variety of professionals in the organization, and we are really able to work as a team without much problem. We design programs together and go out and implement it, come back and evaluate.
Thank you, Francois. Can I suggest, I think that we'll have to close it. I just want to share a few words on a few things. Can I suggest that everyone actually go to the AfroPHC website and join it, and then you'll be on a Google group, and I'd really urge you to share even more there, raising questions and issues and sharing, generally what's going on in your country in primary care. So I think there's lots of good stories which I think are really useful and important to share, but let's use that opportunity. I think I want to just say I'm very grateful for the family physician, Dr. Joy Mugambi, and then Albert Tatey and David Lusale from the African Network of Clinical Officers or Clinical Practitioners. What I want to just share in the last few minutes, if there are any questions, feel free to post them. We could actually answer them a little bit later. But I want to just say that AfroPHC, I'll share with you the website.
I put the website.
Yes, thank you. And I'm just showing you quickly that it is really about trying to get the frontline healthcare workers together. should have actually raised it right at the beginning for those who joined us, and find ways in which we can get voice, that we can talk together, talk to each other, understand each other better, and then be able to speak to, policymakers as to how they should unpack primary care services and primary care healthcare approach in universal coverage. So I think there's lots of stuff to talk about. I think there's already been some very useful discussion about the education that's been going on in and the sort of advocacy in Kenya. I think what David also shared was the variety that exists out there, and the difficulty with trying to understand how they all fit in together across Africa. But I think that the network seems to be doing a wonderful job, and we all hope that we can be of assistance to them. AfroPHC basically is there's a core team that's trying to pull this together, involving David and others, and I think both David and Albert are part of it. We're trying to work to a conference, but we'll have a discussion tomorrow with the core team about whether we move that on virtual or think of a different configuration. I think there's clearly concern with travel considering COVID. We have got this webinar series, and we're running it on it every month. So next month, there'll be another webinar. Please go onto the website and join it and register for it. There's a Google group, which is there as well, and you can join in the discussions. We're trying to put out useful information where you can engage with material. There's also a training, a course that's very useful for anybody in the primary care team. Please encourage them to go and have a look at it. But you can join and then apply to do the training. Apart from that, please keep a tab. I want to just say that Wonka Africa, I've just been in communication with WHO, and we're looking at a webinar on every Friday at 1 p.m. Central European time, which is about, I think, 2 p.m. for South African time. If you can just keep that. So I think it's one hour GMT plus 1, but 1 p.m. So GMT plus 1 p.m. If you can join on Friday, it's going to be around the coronavirus, and there's going to be on this Friday, a focus on Anglophone Africa. Please join the webinar. You're free to ask questions. There's a question and answer session, but it's focused. So if you go to the Wonka Africa website, you'll see it there. And it's in fact, we can register for the webinar. So we're going to do Anglophone Africa this week and Francophone Africa next week. And we're going to look at how to elaborate that. So there's a regular way in which we can have anybody on the ground, anywhere in Africa, being able to have access to some support and ensure that the concerns they have on the ground are heard. So really, I would really strongly advise you to spread the word around, send that link around, and get people to register on that. I'll be sending an email around, so please keep an eye for that. Any other closing comments from Albert, David, or Joy?
Just to say thank you. It's been great listening to what is being done out there, especially Cameroon, and looking forward to engaging further in much more of this.
Good. Thank you very much, Joy. Anyone else? David and Albert?
Mine is just first of all, because this is my first experience on this platform. I'm very grateful, and this is a very good beginning. And as I had said earlier, this is a platform that will definitely take advantage of, and especially when it comes to bringing Africa together. I also appreciate you, Daktari. We call doctor in East Africa Daktari, for this good idea that you came up with, because it will really help us to bring our people together and even make health more affordable, because health is normally expensive because of ignorance. I also want to thank my senior clinical officer in Kenya, Dr. Joy Mugambi, and a very good friend, for having introduced me to this and also guiding family health in Kenya courageously. I can tell you for sure she has also been very useful to us. She is in our scientific conference, especially the reviewing of papers and all that, and we expect to engage her in more other areas. And finally, I also want to thank my predecessor, Dr. David Rusare. He has also been quite passionate, and he has shown us the way in so many platforms, including in even the International Academy of Physician Assistant Educators, and so many other platforms. In fact, he has been opening a lot of windows and doors for us, especially in Africa. Otherwise, thank you so much, and believing that we shall be able to follow up on all those other sessions so that we can be able to participate and also learn from them. Thank you.
Thank you very much. And I just want to close with a comment from Aviwe Ngobozi, a clinical associate from South Africa. I think AfroPHC is a great idea to foster interprofessional teams to drive the agenda for achieving universal coverage. On that note, unfortunately, David's muted, so we'll leave it at that. Thank you all very much. Enjoy the rest of the evening, and we'll hope to see you at the next webinar. Bye-bye, everyone.
Thank you.
Thank you. Thanks,
Bye-bye.
Prof.
Good evening.
Bye-bye.
Have a good night.
You too. Bye-bye.